Everyone, welcome. I'm Michael Morella, Managing Editor for Events at US News and World Report. Welcome to our webinar on succeeding in the new era of virtual care. As so many of you know, the coronavirus pandemic has transformed the healthcare landscape in the way that many hospitals and health systems are delivering care. So we have a distinguished group of experts here with us today to share what they've seen and how they're adapting. Together, they represent more than 100 hospitals and 1,600 plus care centers across the United States. One note, we will be recording today's discussion and sharing video after it concludes. Before we get to the panel, I do want to introduce David DeAngelis, Global Healthcare General Manager for Dell Technologies, for a brief word. David?
Welcome all to what we believe is going to be time well spent discussing what we describe as the next normal for healthcare. This is where organizations continue to rise to the challenge, balancing this ongoing pandemic versus safety for your patients and for your staff, services, and the coming wave of demand. In other words, accelerating digital transformation for both business and clinical agility and being ready for the next big thing. By way of introduction, I'm Dave DeAngelis. I'm the Global Healthcare General Manager for Dell Technologies. Our team includes previous healthcare CIOs, practicing clinicians. It includes healthcare IT consultants, EHR administrators, and a wide variety of other types of backgrounds. For over the last 20 years, Dell Technologies continues to work with over 10,000 healthcare providers worldwide. And our mission is simple. It's to really deploy essential infrastructure from the edge to the core to the cloud. And then at the same time, we interlock with VMware, delivering any device, any application, anywhere. As we look at this accelerated digital transformation, it's really coming from the edge. And as I've talked to customers over the last 6 months, there's 3 themes. The first is an obvious one, a virtual care explosion. There's a 500-fold increase in telehealth and virtual care overnight. Patients have changed their perception, going from an 11% of virtual care acceptance to over 3/4 of the people would like and prefer a patient virtual experience. So as you can imagine, there's a lot of stress on this new model from a technology perspective. And as we're dealing with this virtual patient, the second half of this is dealing with the virtual staff and working from home. And then the third theme that we've seen over and over that you'll hear a lot about today from our panel is around secure care. And how do we deliver this next normal safely and confidentially? In summary, when I look at this, me personally and Dell Technologies, we think this next normal digital transformation presents opportunity. As we transform, there's going to be a big benefit in the future for chronic disease management. There's going to be a huge benefit for patient safety in this contactless environment. And think of elderly not driving in cars. And then the last piece of this is around utilization. If I use an analogy here of technology, we all know how virtualization has just really changed the perception of infrastructure utilization. We think as we virtualize this clinical experience, there's going to be a real ability to scale from a clinical perspective and drive up utilization. So with that, I'm excited to hear from our panel today. We have a great broad spectrum of men and women. And with that, I'm going to turn it over to Brian Kelly. Thank you.
Before we turn it to Brian, I will actually steal the microphone back. Thank you so much, Dave. So as I introduce the panel, I want to encourage you all to visit our events website at usnews.com/events to find more detailed bios of the participants. And if you have questions during the discussion, I see some of you already starting to enter them, please type them into the Zoom Q&A feature on your screen. We'll try to get to as many of them as we can during the hour. So I'll quickly introduce the group. With us today are Suja Chandrasekaran, Senior Executive Vice President and Chief Information and Digital Officer for CommonSpirit Health. Dr. Scott Rissmiller, Executive Vice President and Chief Physician Executive for Atrium Health, Michael Robinson, Vice President for North America Healthcare at VMware, and Jim Roxburgh, Chief Executive Officer for Telehealth at Banner Health. Leading the discussion is our very own US News Editorial Director and Executive Vice President, Brian Kelly. Take it away, Brian.
Thank you, Michael, and thank you, David. I think you framed some really important questions for us to discuss here, and as Michael said, we have the right people to discuss them with. Tremendous experience on the table here. So I want to start just by allowing you all to introduce your organizations a little bit in the context of remote health, which we're casting broadly. We've been using telehealth, I think, in a narrow way, but obviously you've all made clear it's a lot more than that. And looking at it in this immediate context of pre and post-COVID. So if you can kind of where your organizations were pre-COVID with the idea of remote health, and what has happened in these intervening months, as David said, the industry moved forward. Where have your organizations moved? So if I can start with Suja and the very large, complicated CommonSpirit organization, tell us a little bit about what you guys are doing.
Brian, thank you. Hello, everyone. Good morning, good afternoon. I am part of CommonSpirit Health, and we are a pretty large health system, 140 plus hospitals, thousands of clinical locations, about 150,000 employees, and we have the privilege of serving our communities across 21 plus states. Pre-COVID, certainly we were working on various telemedicine, telehealth capabilities, both in ambulatory as well as in acute settings, but COVID certainly acted as a great tailwind, a great propeller towards a lot more. And just to quote some numbers, we were about probably 1 to 2% of our total visits were virtual. We had some bright spots, but it was pretty patchy. And also even within our acute facilities, we did do some virtual capabilities. But during COVID, during those days in March and April, we very rapidly scaled up. At peak, we were at peak in certain pockets of geographies. 70% of our total clinical visits were virtual, and we've gone. It has changed a little bit. It shifted a little bit, but it is not as much as 70% as it was during the peak of March, April, even May. We've come down, but it's still a big portion of where we are. And we are expanding it across inside our acute facilities with inpatient-focused virtual abilities as well.
Okay, that's a big move. Jim, let me ask you. You're sitting there in Phoenix, Banner Health, another giant system with a lot of innovation and also a few hotspot problems now, right? You guys are really pushing the edge of the care continuum with COVID. So how is that doing pre and post COVID for you?
Yeah, thank you, and good morning and good afternoon, everybody. Pleasure to be here. Pre-COVID, Banner has had an established tele-ICU program since 2006, covering about 700 ICU beds. We provide services. We have 28 hospitals in 6 states, over 50,000 employees. And so our flagship program was our tele-ICU, and then several specialty telehealth services, and then relatively small on the ambulatory side, some ambulatory programs. During the beginning of the pandemic, we rose to the occasion, and we've accelerated the ambulatory program. We've provisioned about 7,000 providers and staff in order to enable ambulatory visits. We're on target to do about 140,000 more virtual visits than we've done in the past, maybe up to 200,000. On the acute side, we came up with a rather innovative solution in that for our COVID units And for many of our ED beds, we converted the television set into an endpoint. We can talk more about that later, in order to avoid the use of PPE use and overexposure for our caregivers. So we've, and all this has been done in rapid fashion, thanks to the great IT team, business development team, and the digital business teams. So we've seen a dramatic increase in the foundation that we're building for telehealth, literally in the last 2.5 months.
Okay. And Scott, we're going to go to you. Atrium is primarily in the Carolinas, so we're moving east here. Tell us about your experience.
Sure, and thank you again for allowing us to speak here this morning. It's a privilege, actually afternoon here. So Scott Rissmiller, Chief Physician Executive with the Atrium Health. We're approximately 40 or so acute facilities over North Carolina, South Carolina, and Georgia, 600 plus ambulatory locations, and about 60,000, we call them teammates, employees. So that's sort of the scale of what we're doing. We've been in sort of the telehealth virtual care world for about the past 8 to 9 years. My predecessor sort of put out a challenge of, if we look 10 years down the road, what is that thing that we're going to look back and go, we really wish we would have invested more in this area. And virtual medicine telehealth was the area that the feedback came back 10 years ago, 8 years ago. So we've really developed virtual critical care, virtual hospital. It's mostly focused initially on the acute side of things, virtual specialists, so that we can bring virtual care and virtual specialties to our more rural hospitals. And over the past couple years, really started to grow our ambulatory virtual component of our telehealth program, focusing mostly on those kind of episodic virtual primary care visits, and a few areas such as heart failure and others, focusing on chronic care. But as the story here is very similar, I think, amongst all of us, the progress was slow and incremental, and along came COVID. And in March, just rapid acceleration. And the thing that I'm really proud of is that it was organic from our clinicians driving this. This was not a top-down approach to how to care for our patients. Very similar story to what we heard a second ago. Prior to COVID, about 3 or 4% of our visits were done virtually. At our peak, we are close to 60 to 70% of our ambulatory visits were done virtually. We've settled back down now as things are starting to be a little bit more quote unquote normal, although I don't know what that word means anymore, normal. And one thing we're really proud of is that in just a couple of weeks, we trained 2,300 of our teammates on how to do the virtual visits. And in 3 weeks, we were able to set up a virtual hospital and to care for COVID patients who would otherwise be in our hospital. And this was a strategy, one, convenient care for patients to reduce exposure and spread, but also to create capacity, because the modeling early on especially was showing that we were going to rapidly outstrip our hospital capacity in Charlotte and surrounding areas. So this is a virtual hospital with wearables, the technology device, pulse ox at home, blood pressure cuffs, pulses, et cetera, that are digitally uploaded to the EMR. We're able to send paramedicine, community paramedicine into the home to give IV fluids, IV antibiotics, et cetera. And to date, since it started in March, we've cared for over 12,000 patients with our virtual hospital, run a census of around 2,000. Now, not all of these would be in our hospital necessarily. Some of them are a little bit lower acuity, but a significant number would be in our med-surg beds if it wasn't for this. So we can talk about that more, but that's one area we're really, really proud. And again, this was all organic, driven by our clinicians.
Wow, fascinating. Let's come back to that. I think that's really interesting. That is news to me, and I'm in the news business, so I like to hear that. Michael, you're providing so much of this. What has happened to your business? You must have a lot more friends coming to see you, I guess. And what pressure does it put on you? What have you learned about the technology and its both capacity and its shortcomings at this point? And you have to unmute, Michael.
That would help. Yeah, thank you, Brian. So, VMware is about supporting better outcomes for healthcare organizations. We service and engage with more than 7,000 health organizations across the North America. And there were 5 principles that we were focused on pre-COVID. So we wanted to enable patient care and help deliver better health care outcomes. We wanted to help our customers simplify healthcare IT operations, deliver healthcare services at the edge, to more broaden and empower healthcare workers, and to protect healthcare information and mitigate attacks. None of that has changed, and as we know, health organizations had challenges prior to COVID, around supplies, staff shortages, clinician shortages, but post-COVID, we've seen, mass impact around increase in charity care, 30% decrease in business because of elective surgeries and, shift to critical care. Pre-COVID, most hospitals operated on pretty thin margins, and Moody has moved the outlook across the industry from stable to negative. About 450 rural hospitals are at risk of going out of business. And so, building in business efficiency and the ability to address some of the challenges that the panel had talked about already is where we've been focused. So a couple of things, post-COVID, work from home obviously increased significantly in terms of the capabilities to be able to enable both clinician and non-clinical workers to work off campus. We also focus on security as, with the pandemic, it's become more of a threat in terms of the bad actors trying to get access to information because of this new virtual environment that we work in. And then we focused on basically a few areas. So security, surge and burst capacity. A lot of our customers over the last few months, as has been stated by the panel, really moved from, campus engagement to work from home. So giving our customers that capability, and then looking at it again from a secure environment. One great example that I have, Brian, is at MD Anderson. Prior to COVID, they were looking at how they could use, SD-WAN capabilities to build out satellite sites. But post COVID-19, they've really looked at how do they now deliver care in a different way. So what they've done is they've sent the majority of their radiologists now work from home, and they have a high bandwidth solution that allows them to look at diagnostics remotely, so that those radiologists do not have to come. And now that's the new normal, or next normal, as Dave pointed out, for how they conduct that.
Mm-hmm, mm-hmm. Interesting. So let me, Michael raised two important points that I want to get to. I want to ask you guys about, and not before we get to some of the clinical questions, and that's cost and technology. So are you, the three of you who are in a hospital setting, you're under tremendous cost pressure, obviously. How do you see virtual health? Does virtual health solve that problem, or does it exacerbate it? And then secondly, the technology itself, the underlying technology, are you satisfied with it, or do you find that it is not to the standards that you'd like to be practicing medicine? So Suja, let me start with you on that.
The first objective is always serving our communities and our patients, right? It begins from there, and the practice of medicine and the focus on provisioning care at such a moment of pandemic is always a #1 priority. So in that process, it's what we are doing now is not solving the entire problem. It's not about taking huge problems and and handling an elephant in the room, or solving in big ways, but taking smaller steps and continuing to make progress. I come from a different industry, so I would say that a lot of the technologies I find in this industry are somewhat version 0.5, version 1 in maybe a 10, 15, 100 step journey. So it's not about trying to solve everything and making a leapfrog in the process, but truly driving value in every step of the process that's patient-centric, that's clinician-centric, but making that progress. So in a way, this has been about not the invest $6 billion over 6 years kind of initiatives. This is about making agile improvements and making that impact. But it is entirely about bringing the clinicians together. It's about people and human centricity. And it's a great story on the MD Anderson and being able to get the radiologists to work from home, but being able to support our providers to be able to provide practice and taking technology, taking the care to our consumers and patients where they are. So this is not something, the swiftness with which we are moving is not about cost, it's about making the progress and continuing to make the progress. But the key I would call out would be not to rest in a status quo or not to get comfortable that we have solved it entirely. This is going to be a game of continuing to make that progress and improving. It is about looking at virtual care by care type, by care families. Not all geographies are the same. Rural, we are a fairly large provider of rural care in some of the states. The provisioning of care, the provisioning of support is not the same in different places, but continuing to solve these in different ways. So we're going to be in this journey for a long time, but it is about that ability to make an impact along the way and not wait for that 6 years to show something that probably has shape-shifted entirely when we began the journey. So that's how we look at it, Brian.
Jim, has this helped the bottom line?
Yeah, let me step back a bit. Yes, and I think the focus is on how do we build a strong foundation so that we can provide the best care possible. If we provide good value-based care, the finances will take care of itself. For example, if we provide good right care at the right time, we can move the patient through the process. We can avoid unnecessary costs. If we can provide right care at the right time, we can provide the diagnostic procedures and things that will drive, improve income, but provide the right care. So our focus is really on how do we develop a strong foundation? How do we provide the best care possible, get the clinician to the bedside virtually, and to touch that patient? And when we do that, everybody wins, including finances.
And how about the technology side? Are you happy with the products that Michael and David and your competitors are putting on the market?
I'll say yes, but I'll say I'm never happy. And I say we're always looking to make it better. So, and with that, we want to find out what do the providers need, what do the patients need, and how can we continue to respond to their need. And I think any system that you put in place, the key is the response, because there's going to be glitches, there's going to be challenges. How do we respond to that? And I think we are getting good at that, and we're going to get great at that. And it's all about what does the teleprovider need and what does the patient need in order to get the best care possible.
Any specific things? Michael and David are sitting right here. they could probably get back to the laboratory and make something for you if you wanted to put a fix on something. What are some areas you think are soft?
Well, it's a really good question. I think connectivity. If you don't have good connectivity, you can't have a virtual visit. So connectivity is the key. You know, you talk to a provider that says it doesn't work. Well, you have a bad network connection. Or you talk to a patient that says it doesn't work. Well, you have a bad network connection. So that's the sort of the basis for making everything work. You got to have a good audio and visual connection. And I think if you can establish that, it'll go a long way. And just to further mention my feeling about a strong foundation, we first have to get the audio-visual connection really good. You have to have that. If you don't have that, you're never going to get to the next stage. And so I would say, if you ask me what the biggest concern was, it is about connectivity.
I had a cardiology visit a few weeks ago, and when my cardiologist hesitated, I thought I had a problem, but it turned out it was just a bad connection. So I know what you mean.
Yeah.
Scott, how about your group?
Yeah, so, to the first question around the cost or affordability piece of it, certainly the waivers from CMS, Medicare, and other providers has been crucial in allowing us to really make these leaps forward. I mean, our CEO, Gene Woods, from day one when COVID hit, he said exactly what we heard a second ago. It said, do the right thing for the community, do the right thing for our teammates and patients, the finances will follow. And the waivers have helped with that. But we are at a point to where if the waivers and the coverage in that runs out, I think it will be a significant challenge to continue the progress and the rate of improvement and progress we're making around virtual, because it is a significant investment now. And we have been doing it for many years, so the ROI kind of comes from the fact that we're freeing up hospital beds. We are always running in Charlotte and our other locations at max capacity. So caring for more patients using virtual and other tools to be able to keep patients local, rural, in their rural communities, not everything having to come to our flagship hospitals, is a way to create capacity, and then the ROI sort of follows that. On the ambulatory side, a little bit of the same, but at the end of the day, it does enable us to care for more patients with fewer bricks and mortar and with fewer individuals, but the reimbursement has to stay in place, my belief, for this to be sustainable long term. And I'm really excited to hear that the conversations that are happening at the state and national level around the reimbursement and making this sustainable, because I do think it's the solution, or one of the main solutions, for rural care and underserved. We are the safety net hospital in Charlotte, and our community clinics that we have embedded had a no-show rate of around 25% prior to COVID. And it was due to transportation. Many of our patients were having to take 2 buses to get to our clinics. When COVID hit and we converted our ambulatory visits to virtual, our no-show rate dropped to less than 10%. So from 25 to 9%, simply because they didn't have to deal with the transportation issue. Now, we had issues with the connectivity, and do they have iPads and those different kind of things, and we were able to provide some of that. But great evidence that it really serves our underserved populations who are the hardest hit right now by the COVID and everything else, as well as solutions for rural. On the technology point, I would agree with what's been said. It's connectivity, and also the seamless integration into 2 things. One, the provider, the clinician's workflow. It can't be a side thing that they have to go do, log on to different things, those type of things. And the information, the data needs to be seamlessly integrated into the electronic medical record. Our virtual program is homegrown for the most part. We do use a few third-party vendors in that, but most of it is homegrown and is fully integrated, the care team into the EMR and that's something that the patients really appreciate, and knowing that it is part of the care team and their care plan that is provided to them virtually. So, but on the technology part, we have to make it really, really easy for the patient, really easy for the clinicians. We're not quite there yet.
Interesting. Let me say, Suja, come on in, go ahead.
Yeah, Brian, if I may add, the journey of the consumer searching for care online to being able to find the physician, to be able to then single click into a virtual visit or a waiting room in an urgent care, and then the post-care follow-up, that journey is still friction. That isn't a single journey, right? So in general, as a person, we are doing this, and even when we visit a brick and mortar facility, the patient or the consumer is pretty much the owner of the journey, and they manage it.
Yep.
To make that available digitally, make it frictionless, as well as for the provider to make it frictionless, add caregivers who are part of the conversation. Those are pretty friction. And those are all the places where the investments need to proceed. The audio, video, yes, the network infrastructure needs to be improved, but there is also, even in the operations, the gating, the check-in process, the rooming process. So there is a little bit of a workflow that happens in a physical environment. Will it get replicated exactly digitally, or will we rethink it in completely different ways? And how does that change if there is a very heavy element of an omni-channel component to it? So what happens when there is a diagnostics that needs to be needed afterwards? And is that a mobile squad? And so there still is a long way to go for the industry. And there is a long way to go for many of these care types and care families to get to a more frictionless environment, and technology, data, user experiences, all of us problem solving it together play a role.
Yeah, Brian,
Yeah, please, Michael.
No, I think those are some great points that Suja and Scott raised. You know, obviously COVID has exposed some inequities in our system in terms of, you know, equality of care and how that gets delivered. But there are also, you know, our vision is to be able to build, run, manage, connect, and protect any app on any cloud, on any device, which is really focused on, you know, how do you improve both the clinician and the patient experience by wherever the client might reside. And Scott, Gene, I heard Gene tell a great story about a gentleman who was primarily using the ER as his primary healthcare. And through, you know, active engagement, community engagement, they were able to reduce that significantly. Obviously, they had to provide him with some capabilities, but the reality is that it's not just technology, it's people and process. And to your point, Suja, how you maybe evolve care models long term, right? And I think technology becomes the enabler for that. Another great example we have around virtual health, and you know, most, in my experience, I've been in healthcare more than a decade. You know, most providers are not huge, don't have huge development capabilities. But now, you know, with agile development and modern app development, they're looking for ways to incorporate that patient-centric kind of experience. And we worked with one provider in the Midwest around building a portal that integrated the 40 different disparate EMRs that they had, and so that you get, you know, one version of the truth, so to speak, in terms of the patient information. And, you know, you have to be, to Suja's point, you have to be agile and innovative in terms of how we look at these things going forward. You know, I'm also encouraged by, you know, some of the federal mandates around interoperability and, you know, how do we bring information together. So again, I think it requires partnerships, not just with technology companies, but, you know, integrators and customers that, you know, health systems that are willing to, you know, drive innovation into the marketplace.
That raises an interesting question. We've gotten a number of questions from the audience, and a lot of them on the health equity issue. And interestingly too, the combination of health equity and technology. So this, you know, is stable internet connectivity a new, quote, social determinant of health? Which in fact, it is a factor that we use in our ranking of social determinants of health. But is that, I mean, is that ultimately a government question there, where that backbone, that infrastructure is something that becomes fundamentally important to your work, to each of your work, that the government really needs to, you know, make a new superhighway system?
That was how I was going to put it. I do think it's the interstate of 2020, right? You know, back in the 1940s, 50s, it was all about building the highway and the infrastructures and those things. I think that's what we see right now, and I do think the government needs to step in and really focus in this area. We have a hospital system in Georgia, South Georgia, that is the hub for a large rural footprint. And we've been partnered with them for a little over a year now, Atrium Health, and we are bringing our virtual capabilities to them. And it's looked at as a great solution for, again, their rural health strategy and reaching people, but the broadband just isn't there in many of the areas to be able to deliver that care. So I do think that is crucial for us to really take this to the next level.
Other thoughts on that, Suja?
Yeah, so a couple of points. It's multimodality, right? So the video is one form factor, but the multimodality of an audio visit or other forms, we have tried to help some patients by taking them Meraki devices. We have taken Wi-Fi devices to places and helped them get on board. But thinking about the whole continuum of care, our go-forward approach focuses on virtual as a community-focused, so guided care that takes, let's say, an example of a woman, she's pregnant, and following her and giving her a guided care throughout her pregnancy and a post-pregnancy follow-up, then on to the various ambulatory settings, and then acute within the hospital, various virtual care within the hospital, but also post-acute. So the home care and the health at home and the various capabilities around home, and being able to provide the full solution for provisioning care at home, in which these could be options, are also part of the thinking. And yes, it does play a role in health equity. We have to be pretty smart and clever and partner as a group to solve and make sure that this doesn't create other forms of inequities, but rather it plays an active role in solving the inequities. I remember my days from one of the largest retailers in the country. This was back in 2010. And mobile apps and mobile shopping was there, but it wasn't to the extent it is today in 2020. And we told ourselves at that time, the demographics of customers we serve is a certain income demographics, and they will never go shopping online. But boy, did we get surprised. The adoption of technology, the adoption of the mobile device, and being able to embrace commerce in those different forms of modalities almost became an equalizer. And I would like to see the same in this industry in healthcare in different ways in the way in which we're provisioning care.
Yeah, Suja, I think that's a great point. One of the things, I spent 5 years abroad in the Middle East and Africa, and we saw how technology kind of leapfrogged. This is in the early mid 2000s. Mobile technology kind of leapfrogged because of the lack of infrastructure. And I think we're at the same type of precedence now, where you can utilize mobile technology to solve for some of those inequities. And at Dell Technologies, again, we believe that that collaboration has to be with both our partners and our customers as well, to make sure that we're doing that. And I agree with you. I think the technology can create a broader chasm, and what we want to do is actually shrink the chasm. So
yeah, let me just add there. I think those of you that were around when the electronic medical records came in saw the pain of the physician suddenly being given a new way of doing things. All they wanted to do was see their patient. And we need to be careful that as we roll out our telehealth platforms and our solutions, that we don't get in the way of allowing the provider to see the patient virtually. And so as I can go to Amazon and in a few clicks I can buy something, we need to create the kind of infrastructure that allows the provider to virtually see and touch their patient. And as was mentioned, across the continuum. If I'm a physician and I'm a specialist, I see a patient in the ED, I should be able to follow them into a rural clinic or near their home in a seamless fashion. And we're working towards that. And in addition, not only within the system where the application is launched within an EMR, but we need to be able to do it outside of that EMR. How do we deal with multiple hospitals or systems that may have different EMRs? So we need to be thinking about how we manage that so that the provider can very simply assess their patient, follow up on their patient, and make that access so simple for them that they can do what they went to medical school to do.
Amen to that.
Mm-hmm.
So sort of in that same space, I think, Jim, a couple questions from the audience about, very specific devices, wearables and remote monitoring. And one question is, does it improve outcomes? And another question is, are there faulty diagnostics on this? Are we getting bad outcomes? What has been your experience with the actual physical monitoring of people at home?
Well, that's make a lot of advances, and there's different types of ways of doing the monitoring. One is intermittent monitoring. Actually, the basic way is to ask the patient, what's your pulse oximetry reading? And in a lot of cases that works, and you can hold it up and see it. And the next is intermediate monitoring, which is maybe once a day. And then the third is continual monitoring, where you're tracking them 24/7. And it comes down to how easy is it for the patient to use? How do you train the patient? How do you get it to them? What do you do when you're done with it? And how easy is it for the caregiver to provide that type of a monitoring? And I'll say, in my experience in the last 10 years doing telehealth, I've seen all types, and I've seen the challenges. And what happens when it fails? It becomes a phone call. So we have to get real good at making sure that if it's a patch, it sticks on and it works, and the patient's trained, provider can use it and follow the patient.
Mm-hmm. Scott, you were talking earlier about monitoring COVID patients at home. What you could go a little deeper on that. What did that entail?
Sure. we had two floors, if you will, of the virtual hospital. The first floor was more what we call our observation unit. So that was for the lower acuity patients. And we had very clear criteria of clinically which floor you were on to make sure that patients were cared for in a proper way. So the first floor really was OBS. It was checking in with them multiple times a day. And we were able to do pulse ox, blood pressure, and pulse, and it was intermittent, as Jim sort of pointed out. It was not continuous. The second floor was really much more intensive, and that was frequent touch points throughout the day by the care team and the nurse, with them virtually, frequent blood pressure, pulse ox checks, and those type things. And then we were able to send in community paramedicine into their homes for checks. If we saw maybe they were going in the wrong direction, we were able to give IV antibiotics, IV fluids, et cetera, and really assess them. And what I will say is we've cared for almost 12,000 patients now in the past 3 months in the virtual hospital, and the outcomes have been spectacular. And the feedback that we hear from, and I know that's anecdotal, it's not a trial or anything along those lines, but the outcomes have been very, very strong. And the feedback from the patients has just been remarkable. We have a practice that Gene Woods brought called Connect to Purpose, where we start every single one of our meetings as an admin team, executive team, with a story that connects us. And over the past month and a half, I think almost every single one of them has been related to the virtual hospital, it seems, because patients really appreciate being able to be cared for in the comfort of their home and knowing that just a phone call away is the cavalry to come in and care for them if and when needed. The wearables are just, as others said, just a tool in the toolbox. It gives you the important diagnostic information, but we all know nothing is more valuable than that conversation, that face-to-face, and looking at them and asking the questions and that. But we were able to have them integrate into our EMR digitally through their phones and that. So it's been very seamless. And again, our teams pulled that together in a matter of weeks, which was pretty impressive.
Suja, your experience with this remote monitoring?
We have the same. We, with patient consent, we do have ability to contribute this data with Apple, and Apple has the ability to share the data back, integration back with our EMR. We do have a virtual hospital setting, and wearable is certainly a big portion of the future, inclusive of 5G. Whether it's even within the acute setting or in outside settings, wearables are clearly a go-forward path. Technology is improving, accuracy of the readings are improving, the network and the reliability of the network to be able to get a continuous feed is improving. So I think where we are today is just an indication of where the art of the possible and where this is going to go.
Michael, go ahead.
Excuse me, I was just going to add, Brian, we've implemented what we refer to as COVID at home, and it's relatively new, but I'll say the success of the program initially has been because we start the process with the patient in the hospital. And so they leave the hospital and their support feeling very confident in the use of that. And that's been a learning I've had over the years, and we've implemented this at Banner, and initially we're seeing good success with it.
And as we said earlier in the show here, you have had a real surge there in that Arizona area. And has that been a factor in being able to hold that off?
We'll see. It's a relatively new program. Our support for the surge has been expanding our ICU beds using the converting the TV sets into endpoints, and support the expansion within our hospital and rapidly getting to the patient and moving him through the process. But we'll to be proven will be the COVID at home, which we feel very confident in the initial rollout of helping to move the patient out of the hospital sooner. But as I mentioned, the practical application is training them while they're in the hospital so they leave confident that they know how to use it and it works.
Mm-hmm. So Michael, I wanted to ask you, give us an industry perspective on devices and monitoring and all that.
Yeah, so again, we think that, evolving healthcare models will be done at the edge. And so again, around our any kind of vision for healthcare, we think it's really important that, those devices are enabled, but they're also secured. and they're also, utilized. And so adherence is a huge factor in terms of whether or not, remote virtual care is successful or not. And so, I go back to technology is great, but it's also people in process and making sure that, that the caregivers are following up, and also that you're expanding the care team to, individuals in the home and others that can help to make sure that that happens. But, from our perspective, the Internet of Medical Things is going to be absolutely critical to virtual care. And our perspective is that it has to be secure and protect patient data in order to do that.
Right. Number of questions from the audience related to regulation, federal and state. A particular question about obviously with virtual health, physicians are crossing state lines, right? How is that handled? And then more broadly, how do you feel about the federal government and the states in the context of this pandemic? Have they made your lives easier or more difficult? Scott, you're smiling, so I think you must have conjured up an answer.
No. Certainly the reimbursement waivers, and that has made our lives much easier to accelerate the technology in that. The regulations around it, state lines, that is still a challenge. We have to get each of our clinicians licensed in each of the states we do it in, so that's always a cumbersome process. So I think certainly focusing on making that easier would be a win. But again, I just go back to the two things that I think the government can do to really help us here is, again, the broadband connectivity across the country, and again, especially in our rural communities. And then the second piece is allow reimburse it as we are now, so that we can continue to do these things that we know are going to lower cost of care for our patients and for healthcare in general. But to do that, we have to be able to at least cover the costs of the innovation and the work that goes into this. So continuing the waivers, the reimbursement that's in place is going to be huge.
Yeah, I would add to that, Scott. I don't think that they're going to be able to put the genie back in the bottle in terms of delivering care across states as well. I think that that's something that will continue to proceed. But I think the reimbursement is absolutely key, and so I don't see that genie going back in the bottle, so to speak.
Thoughts, Jim, Suja?
No, I would agree. Cross-state licensure is critical. The VA can do it. Why can't we figure it out? And so I think we need to make things simple. That's what telehealth is designed to do. So agree with the comments that were made.
There is an element of scale. If you look at the disruptions in other industries, there is an element of scale and applying technology to a broader base that was crucial to the disruption. And that scale is possible in health, but it needs the regulatory support. And the regulatory support that was opened up and the waivers that were opened up during COVID were fundamental for this rapid scaling. The technology is a portion of it, people and mindset is a portion of it, just the dire circumstances of the infection or a portion of it. But in that March, in the third week of March, had the precedent and were those waivers not there, we wouldn't have seen this. So that cannot be forgotten. I think Seema Verma said that the genie is out of the bottle and not all of the genie is going to go back. But to see that through, to see the same level of payment coming in from the commercial payers, the same kind of regulatory acceptance from the state level, that's got to be crucial for this kind of a disruption, which will improve across all of these: access, affordability, being agnostic across modalities, and overall reducing the cost. So it has to be a crucial part of this conversation.
I hope we have some legislators in the audience. We usually do when we sit in our Washington hotel, as Michael knows. You can't escape this. We always have a great participation from the folks who make some of these laws. But
yeah, we spend a fair amount of time on the Hill, trying to help these things along. Right.
Well, it's interesting that there does seem to be somewhat of a change in the mindset, more acceptance. You've all touched on this, but it's come back, and I think it's worth taking a deeper dive, which is the actual clinicians, the doctors on the front lines, and what is their acceptance, hesitation about this? Where do we stand in terms of them embracing it? I mean, Scott, you started by saying, there was an organic shift to really embrace this problem from the folks in the trenches. Do you think that's going to be now across the board, or where do we stand with actual doctors? And I think, Jim, your analogy with EMRs was a good one. There was a lot of pain there for a long time. Where are we on that continuum here? We'll start with Jim and then go.
Thank you. Yeah, I think to build a really solid telehealth program, you need to start at the bedside. And you need to know first of all, what's needed, and then you need to work with the clinician. Again, I'm going to say it again, how can I get that provider to seamlessly touch the patient without a lot of clicks and clunkiness? And when we can achieve that, physicians and providers can do what they went to medical school to do. And so that's part of the challenge that we have in the telehealth space, is that making it very simple. It's not rocket science. If I can pick up my smartphone and touch an icon and get my bank statement, or touch another icon and get music, why shouldn't I be able to use a similar type of a process and virtually touch my patient? And so that's how we need to think about this. And I think the mistake that we make is we come up with great technology and come back from a conference and say, here it is. And the provider says, whoa, I can't figure that out. So we need to make it very simple for the provider and easy access. It's really, again, that simple.
Mm-hmm. Scott, your fellow physicians, or where are they on this?
Yeah, I think Jim and I think very similar on a lot of these issues. We have the adrenaline from the crisis initially. Everybody was ready to jump in and do whatever it took, no matter how clunky it was, because everyone rallied around the patient, and that's what we do, and we continue to. But we have to make it easier, and the technology has to integrate fully and make it seamless. I would not focus purely on physicians, though. I think virtual visits by nurses, virtual visits by nurse practitioners and PAs are great ways to extend the team and allow the physician to really focus in the areas that they can bring the greatest of value. So in many ways, I think the virtual helps build out that care team that we've always talked about, in caring for more patients in different ways and lower costs. There's silver lining comes out of every crisis or challenge. Going into COVID, we were pretty advanced in virtual care, but we still had all the naysayers, can't do this, nurse practitioners or PA can't do these kind of diagnoses, blah, blah, blah. The crisis comes, everybody jumps in and just knocks all of those sort of barriers out of the way and delivers really, really great care. So, in a couple months, we have, from a cultural standpoint, I think, and I don't think it's unique to Atrium, I think it's across the country, I think we have busted through a lot of those artificial barriers that were put in place because either people don't like change or are resistant to it. And we've burst through that. Now I think it's blue ocean. I think it's time to run and go. And I think we see that. And I think our clinicians are on board with that.
If I may share that, Brian.
Suja and Michael.
I saw this here. We were talking about a problem to solve or a user experience to address, we were talking about a vendor product. So we would say, let's implement X, was the way we would begin the conversation. To change that was a culture change, right? What problem are we solving? Who is a human? Who is the persona? Who's at the end of that? Who's going to experience that? And what is the journey that they're going through that we're going to infuse something? And how would that journey flow through? And everybody coming together. And to the earlier question, there is a slight margin improvement in the virtual visits in the clinical settings. But even on the acute, it is about automation. It's about productivity. It's being able to create the hubs and doing it. But those are only going to be possible if everybody's pulling together. And it's a human centricity. Any of these changes about human centricity and not technology centricity.
Agreed. I just wanted to amplify what Scott said, Brian, a little bit. First of all, as I stated earlier, there's a clinician shortage or a physician shortage in general. So I think the number is about 2.6 per 1,000 people in the US, where we rank 13th in the world. So, there was a problem pre-COVID. And to Scott's point, I think the expanded care team is going to be absolutely critical, but we have to make sure that, and to Suja's point, the advanced stages of meaningful use require us to improve both clinician and patient experience. And so, focused on the human centricity of that, I think is absolutely critical to get the advancements and agility that we're looking for in the outcomes.
Interesting. Scott, you made that point about it's not just the physician. There are other aspects of this, and a good question comes in on the specific areas of mental and behavioral health. And are there particular strengths and weaknesses of virtual health with regard to those areas, mental and behavioral health?
Well, we only have 4 minutes. I could do that for a couple hours. We have invested significantly in behavioral health, and I'll do this quickly. We have about 60 psychiatrists, 2 acute behavioral health hospitals, and a behavioral health ED, and still don't even scratch the surface of the need out there. One of the things that we've been able to do is develop a integrated behavioral health into our primary care. So we have virtual behavioral health in 60 of our primary care offices, that if the patient fills out a screening tool, and if they show that they may have some behavioral health issues, they can do an immediate visit with a behavioral specialist while they're in the primary care office. Diagnosis, medications can be prescribed, and then they're tapped into ongoing longitudinal care. So really has helped bring that. We're also embedded in our hospitals in that, but the virtual behavioral health in our primary care right at the front line has been one of our greatest wins in the virtual areas.
Interesting.
And Brian, I would add at Banner, we have focused on primary care and doing a depression and anxiety screening and tracking the patient and following them in the outpatient setting. And then also through the use of our social workers doing telebehavioral visits and helping to triage to bring in psychiatrists when necessary. It's a really good continuum of care solution. And as Scott said, we're barely touching the tip of the iceberg. We need to expand it more, but it's a really good opportunity for us. And it's a good example of how telehealth can touch a continuum of care.
Suja, CommonSpirit, any thoughts on?
It's a priority. We are more to come on that.
So I think I have an idea for the next virtual panel here. It's a topic that I think does sometimes get pushed to the side, and it does seem that virtual care might be particularly good for these kinds of conditions. So that's something we need to look at much more closely. Michael, I'm going to give you the last word here to wrap us up and tell us where are we going.
Yeah, so I really appreciate. It's been an honor to be able to be on this panel, Brian, and Dell Technologies and VMware. Work collaboratively with all of your organizations, Suja, Scott, and Jim. So thank you for that collaboration. We really are appreciative of all that you do on the front lines of this crisis, but we also believe that there is opportunity as we come out of the crisis and we collaborate going forward. So looking forward to working with all of your organizations, across the board in terms of how do we improve the outcomes that we're trying to drive. We're all mission driven in this industry, and I think that's a great thing about working in healthcare. And so, we look forward as a technology partner to figuring out how we help you innovate and how you help you solve the problems that you have. So thank you all. We really appreciate you guys participating. It's been insightful for me, and I'm sure it's been great for the participants as well.
Good. Well, Michael, thank you for that. Thank you, Jim, Scott, Suja. It's been a privilege for me to spend time with you. I don't want to take any more of your time because you've got some pretty significant work to do, but it's really very helpful to get your insights and to be able to share them with our broader audience. And I will sleep a little better tonight knowing that you guys are all on the front lines doing a good job. So just keep it up, and we'll hopefully talk again. So take care, everyone, and next time.